Live at lunch, I thought I would come and talk about chronic kidney disease and how a ketogenic lifestyle affects that or works with that. I've had a lot of people ask me recently about chronic kidney disease, whether they can do a ketogenic lifestyle with chronic kidney disease. I have a number of patients with diabetes, and they end up having chronic changes in their kidneys because of that. A lot of people don't know what chronic kidney disease is, so I wanted to define that a little bit first. We'll talk about what it is, how the damage arises in that disease process, and then secondarily, we'll talk about what the ketogenic diet does to help it, at least as far as we know thus far. So something to consider that way. Let me turn on my slides here so I can get set up. So what I'll do is we'll talk about that. What I'll do is I'm using a little bit of a change in format with this here, so we'll see if this works. So, whoops, that's kind of weird, isn't it? It came up funny. Anyway, we'll do. So basically with chronic kidney disease, let me pull this out because I'm going to change up my shared screen there. And I think if I recall correctly, we should be broadcasting to my Facebook Live page. So if you have questions or you have trouble hearing me, please type that into your comments below. So it should be rolling to my Facebook Live page. If it's not, I'm in trouble, but we'll see. And then what I'll do is later this evening, I'll upload this video to my YouTube page, so it's available on YouTube as well. And hopefully it'll be all right. So what I wanted to talk about with you in regards to is what exactly is chronic kidney disease. So if we look at the kidneys, and I'm going to shift this so you can see a little more clearly. This is your kidney right here. Hopefully you can see my mouse. And microscopically inside the kidney, in these little areas right in here, you have what are called glomeruli. These are the filtration systems. These are cells that actually filter your blood and filter in or out the proteins and the salts and the various things that you need. In a healthy kidney, the blood flows through this area here, and the urine is created, uric acid and the water and salts are pulled out, and they collect into a duct and end up going into the kidney, and you end up urinating them out. In a person with disease in the kidney, what happens is the membrane around these filtering systems thickens up. And so it's kind of like if you think about shooting a fire hose through the back of your sliding, your screen door on the back of your house or your screen on one of your windows. You have this high pressure moving through a very delicate screen. And what happens is when there's damage, either high insulin or high sugar, it causes that membrane to thicken up and to have some gaps or some spaces that pop open in that area. And then you end up starting to leak out proteins and various other products. And so you end up not filtering correctly, and you end up losing stuff that way. So Donna just jumped on and said she's listening on Facebook. Good. Hello from Northern California. And hello, Rhonda. How are you? Thank you guys for joining me. So basically with chronic kidney changes, because this filtering system is goofed up, you start losing protein, as you can see in this diagram right here. So that's the important thing to look at. So one of the things to be aware of. Now, so what exactly is chronic kidney disease? Well, it's persistent damage or a decreased kidney function that lasts for over 3 months. Now, how do you know that that's damaged? Well, we look at some blood testing that's there. We look at something called a GFR, or a glomerular filtration rate. Hey, Brenda, how are you? And we look at creatinine, which is a measure of one of the essentially a protein that passes through the kidney at a specific rate, and that tells us how well your kidney's filtering. So creatinine level basically tells me about the filtering capacity, and the glomerular filtration rate tells me about the filtration speed. And between those two numbers, it tells us if your kidney's working properly or appropriately. Now, you can actually see, and I'm going to switch screens here, and I'll define this for people so you can see it. And I'm using this new slide deck, so it's kind of, let me flip it this way so you can see a little more. So chronic kidney disease is essentially damage over 3 months or longer that's persistent. That's chronic. If it's acute, it's within that 3-month window. So sometimes you can have some changes that occur within that 3-month window, and then it improves. But it's persistent damage that occurs because of some abnormality that's arising. And you can either see that through a biopsy, through imaging, through blood testing, or the amount of protein that you're excreting. And like I said, there's this GFR, or this glomerular filtration rate that decreases more rapidly than you should based on your age. Now, that rate will decrease after you get to age 50 or 60. You'll start to see that rate decrease by about 10 points every year. But if that rate is decreasing too fast, then that flags that there's a kidney problem or that there's kidney damage. And so that's one of the things that we were looking at specifically in regards to how is the kidney working and what's it doing. So what diseases can cause the kidney to be a problem? Well, there's a number of things that can damage the kidney over time. And this is why doctors like me and other docs will actually look really closely at diabetes, autoimmune diseases, systemic infections, and specific drugs, and even cancer that can damage that glomerular, that filtering system significantly. Atherosclerosis, which we've talked about a number of times with on my site, as well as with Dr. Barry recently. We talked about how insulin can increase blockages and atherogenesis or atherosclerosis of the vessels. High blood pressure does it. Poor blood flow to areas can cause it. Vasculitis, which is inflammation of the blood vessels themselves. Other changes to the microscopic vessels. That's what microangiopathy is. Kidney stones, obstruction of the kidney because of a stone or other causes, chronic infections, and even polycystic kidney disease. All of these can damage that filtering capacity or that filtering speed of the kidney. And there'll be a change in the GFR, or that glomerular filtration rate, and there'll probably be a rise in the amount of creatinine that passes through that kidney. So those are the two things we're looking at very, very, very frequently. In my diabetics, I look at those every 3 months, and in my pre-diabetic patients, I look at about every 6 months to ensure that what we're doing with diet and possible medications that we may be using are not causing changes or damage to that filtering system. And so that's really important to be aware of. Let me click here so I can see where we're at. So basically, if you have various things that, so if you start seeing an increase in the creatinine, or we see a decrease in the GFR, your doctor will say, hey, you're starting to see some acute changes. If those changes last for more than 3 months, then that's considered chronic. Now, chronic kidney disease is often abbreviated CKD, or chronic kidney disease is the fancy term. And when I came out of school, we were told that it was not reversible, that once you had it, it would progress unless you tightly controlled the sugars. And even then, when we did everything that we used to do with the standard American diet and all the medications we had, unfortunately, these diseases progressed. This is the cause of my father's death. He was at an age, he had his first heart attack in his early 40s, and then he ended up having repeat heart attacks that had to be, those vessels had to be, the bypass vessels had to be stented. Then he ended up going into renal failure, which because of chronic kidney disease progressed to the point where he was on dialysis for the last few years of his life. And that dialysis ended up causing the major problems that ended up causing the end of his life at age 58. And so this is something that hits home to me, and it hits home to many of my patients, and it's something that's very worrisome in that regard. Let me just show you real quickly. This comes from Up to Date, which is one of the programs that I use when we look at it. It's one of the software sites that we use that helps us stay up to date with all the literature that's coming out. And this just talks about the decline in GFR over time. As we age, we'll see a decline in the speed. We measure the clearance of a little molecule called inulin, and based on that speed of that clearance, it tells us whether you're normal. Now, if it's above this line here in men, you're normal. If it's below this 9, you fall into the abnormal range. And so we want to stay somewhere within this standard deviation range, following along this line. So you can see that at age 60, you'll roughly have a GFR around 100. At age 70, that'll drop down to somewhere around the 80 range, and then it'll drop down into the 60s at age 80. So you can see that with age, that filtration rate and that filtering system declines. But if this declines more rapidly, then you have a problem. And that's why we check blood work so frequently with a lot of our patients, is to determine, is this a problem, especially in pre-diabetics or diabetics, because I start to see loss of proteins even in my pre-diabetic patients, which is a challenge. So that's important to understand. Obvious symptoms you're going to look for. John asked, well, people, when people's kidneys aren't working, they're going to start to feel more fatigued. They're going to start seeing anemia, because the kidney produces a hormone that helps your bone marrow work appropriately. And if that kidney's not working right, it won't produce that hormone, and you actually will start to see anemia rise. You can start to see a rise in potassium, a change in sodiums and some of the electrolytes, and you can see a rise in uric acid levels. And then in real severe cases, you'll start to see uremia, which is an elevated uric acid level, and you can also see leg swelling and swelling around the belly. So which then progresses into chronic toxin buildup within the body, because the kidneys aren't filtering that out. So great question in that regard. What symptoms will you start to see? Those are all things that you start looking for. So chronic fatigue that's not getting better, chronic anemia, leg swelling that's not improving. Those kidney is one of those things that I always want to look at to see what's going on. So thank you, John, for that question. I'll pop that up there. That was his question there. So, so what exactly is are we measuring in regards to protein? And this is probably more than you want to know, but I'm going to pop this up here anyway, just because it'll give you some data. Actually, let me do this. Maybe you can see it this way. It's not working that way either. It's not working. Let me pull this. And I'm going to pull that down for a second. So hopefully that helps there. Billy, oh, you know what? Can't hear. Oh, I'm sorry, guys. So when I put that slide up, my mic is not linked to it, apparently, and so it turns the mic off. So I apologize. So that slide was supposed to say that based on those three, and I'll put it up side by side here. Maybe that'll work a little better. And you still can't see it very effectively on this screen. It's kind of crappy. Let me see if it works this way. So in regards to the mild, moderate, and severe, I'm looking in my pre-diabetic patients to see is that mild, is the mild protein loss present, because that's a flag that we really need to be careful with what the kidneys are doing. If it's moderate, that means you're starting to see damage already, and then over 300 is worrisome that, hey, you're starting to see some pretty significant problems, and we're progressing down the road to more end-stage renal disease and things of that nature. Hopefully you can hear me now. I hope you can hear me now. It looks like the mic is on. If you oh, there we are. Okay, good. Thank you guys for telling me that. When I put the single slide up only, I lose my microphone. So that's the story there. So I'm going to pull that one down. And so now, what exactly does a low carbohydrate diet do? Why would I talk about kidney disease and low carbohydrate diet? Well, they did an analysis of over 1,000 individuals. And I'll put this slide up here, and you're probably not going to be able to see all of it or read all of it. But basically, this analysis, this slide set, this was done by the, I think it was Department of Endocrinology and Metabolism in Kyoto, Japan, back in 2016. They did a meta review of, I think, look at how many trials it was. I want to say 19 trials, I think is what it was. They reviewed a number of trials, and we were able to gather about 1,000 patients together and look to see, when we put a person on a low carbohydrate diet, does it make any kidney disease worse? And they actually showed that it does not. So there's no changes or problems when you use a low carbohydrate or ketogenic diet in a normal kidney. One of the big factors that people always said, well, you can't use an increased amount of protein with people who have renal disease because that's going to cause them to get worse. Well, in normal people, we know that it doesn't change it at all. In bodybuilders, it doesn't change it at all. You can see that. So then when we look to see further, well, what happens if we compare the two diets? So what if we do a low carb diet versus a low fat diet? Does that seem to change things? And this study that was done in the Clinical Journal of American Nephrology, yeah, you can bring it up, that in 2012 showed that when you compare the two, the low carbohydrate diet actually outperforms the low fat diet in improving kidney function. And so that's they actually did. There was no harm or no problematic effects to GFR, albumin, or other electrolyte balance when you used a low carbohydrate diet versus a low fat diet. So that was helpful to see that there. So using these diets with normal patients is not any different than a low fat diet, which is what you usually recommend when you have someone who has a kidney issue. And then lastly, some interesting studies, and this was published in the I think it was in the PLOS magazine. And I'm going to put this one up here. Let me pull it up here this way, and I'm going to switch so you can actually see. Oh, you can't see my head's in the middle of it, but hopefully what you can see here is that they looked at 4 different slides. When the kidney starts to get damaged, this is the GFR, or the glomeruli. This is the filtering system of the kidney, and what you're seeing here compared to this one here is you see increased number of cells. Well, that increased thickening of the cells keeps the kidneys from functioning correctly, and you actually start losing proteins between the gaps in these holes, and that ends up leading to kidney disease. What they found was that when they put an animal on a ketogenic diet, and you can't see it under C, but the ketogenic diet in C and E actually improved, and the non-ketogenic diet did not. And so a ketogenic diet actually helped the chronic kidney disease, and this is in an animal study with mice. There's not a human study yet with this that's there, but I see this same thing happen in humans in my clinical practice when I use ketogenic diets, and I have for over 15 years. I'm going to show you some data to show that. And hopefully it'll be clear. Let me just change the positioning so you can see. And I realize it's much smaller, but you can see between B and C, a much greater thickening on the histologic slide, increased cellular change around the glomeruli, causing the damage that causes that increased protein loss on B versus C. And then similarly, same way with D and E. D is the rat that was given regular rat diet, and then E is the mouse that was given. I should say not rat. These are mice. This was a mouse given a ketogenic diet. So something to understand and see, and this is actually really exciting. This was published back in 2011, and it was actually one of the really exciting things to me, because I'd been seeing these results in my patients, but there was no study to actually show, hey, this is what we're starting to see in mammals. So I'll pull that out for a second, and let me switch to the other thing that's really cool. And this is a study that was done in that same study. And let me pull this one back up here, and I'll switch screens to this like this. And again, my head is in the way for this. There's no way to move it over. I wish there was a way to shift it, but there's not. So this particular study showed that when you're in ketosis, the ketone level is protective. The higher the ketone level, the more protective effect that arises. In the presence of glucose and in the absence of glucose, the kidney is more protected. And I won't go into all the components of it, but being in a ketogenic state more often is actually very, very protective to the kidney itself. And that's one of the things that we learned in regards to this particular study in 2011 as well. So let me pull that down. So what does this all mean? What does this mean to you and to me? What does it mean to patients with kidney disease? Let me show you a patient of mine that I've been following for quite a while. And this patient we started seeing back in, and I'm going to see if I can pull it up here. Let me switch it this way for a second. So this is a patient of mine. He's a 71-year-old patient that saw me back in 2010. Now in 2010, I wasn't putting people on as tight of a carbohydrate restriction as we used to. It was about 30 grams either per day or 30 grams per meal. This particular patient was a diabetic patient, so he was doing about 30 to 60 grams of carbs per day. You can see over a period of a year, he lost about 40 pounds. His hemoglobin A1C test dropped from a 6.4 to a 5.8. And this is the microscopic protein being lost. Now, when you hit 2200 on protein loss, you actually are ready for dialysis. And his nephrologist had sent him to me and said, you got to lose weight or we're going to put you right on dialysis. And so he came to me with the goal to lose weight. Well, he lost 40 pounds. He dramatically improved his blood sugar. Now you'll notice that his blood sugar did go up over in January of 2011, and he admitted that he has a number of grandchildren and that he ate all of his grandchildren's Christmas cookies, and that's why the sugar went up. And he was honest with me, so I appreciate that. But even then, you can see that he still had improvement in that kidney function and in his loss of microscopic protein in his urine. Now he went away for a couple of years, for 2 years, and then he came back and he fell off the wagon while he was gone, and he regained the weight. But amazingly, he maintained that kidney function. And then even 4 years after we started this this process, he dropped that loss of protein down to 300 and reversed it from severe kidney disease to moderate kidney disease just with his dietary change. Amazingly, we were able to take him off of his Zocor, and we were able to take him off some other medications, and he's controlled his diet. He's controlled his diabetes really well with just diet alone for quite some time, even through today. I don't have the data from today. This is an older slide set, but I want you to see that. Let me just change position so you can see this number right here. It says microalbumin underneath my screen here, but you can see that it dropped from 2,200 on his microscopic protein loss down to 399 over a 4-year period of time. And I see this frequently over and over again, and it's actually pretty impressive. Something that's quite impressive that I see. Let me show you another slide of another patient. This is a patient that had a Roux-en-Y procedure. She had a gastric bypass. I'm going to pop this one back up as well. And again, let me change positions. She had a gastric bypass done and regained all the weight back a few years after the gastric bypass. Came into my office at 200 pounds and was struggling. So we put her on a ketogenic diet. You can see that her cholesterol levels dropped from, specifically her small dense particle, which we've talked about before in the other cholesterol videos, dropped from almost 700 down to less than 90. You can see that she dropped her A1C from 5.7 down to 5. And her microscopic protein dropped from 50, which is in a moderate range, to normalized less than 10 in that 2-year period of time. Pretty impressive in that regard. She dropped her fasting insulin from 22 to 4 and lost a significant amount of weight, about 80 pounds, and is doing really well maintaining. We've taken her off of, I think, all of her medications except for her asthma medications she's been able to come off of because she's doing so well. So this is pretty common. A pretty common thing that I see and have seen over the past 15 years in doing a ketogenic diet with patients that have chronic kidney changes or chronic kidney disease. So something that is just really, really important to understand. So I hope that gives you some insight into what's going on. And I've got a few minutes here. Maybe I can take some questions from you guys. And I appreciate you guys hanging in here. Hopefully you can still hear me. Let's see. This is there we are again. Hopefully you guys are still there. All right. If you guys have questions, pop them in the screen. I'm using something called BeLive. It's their beta version, and I don't know how responsive it is from the questions that come off of Facebook. So Kimberly Middleton said, "Is that the same for MCD?" Kimberly, define MCD. What do you mean by MCD? What acronym are you using there? Can you define that? Let's see. Nancy Mooney says, "Thought Dad might want to listen." Oh, okay. You're forwarding it on to Dad. You can see me in the corner. Yes, you can, Lucy. All right, good. All right. So most of these patients most of these people are saying that they can hear me now. If you guys have any questions, I'll give it a minute. Oh, here it is. Okay, let's see. John Newbert says, is there anything about kidney disease that might prevent or inhibit ketosis? If you already answered this, we lost for a bit. Some of the medicines that you may use treating the diabetic side, or if diabetes is the cause of the kidney disease, some of those medicines, specifically medicines that are going to stimulate an insulin response, will prevent ketosis. Like some of your, we call them sulfonylureas, so glipizide, glyburide. These medicines will stimulate an insulin response, and that will kick you out of ketosis and cause a challenge. So what I usually try to do is put people on a diet that will allow me to wean them off those medications, and then what we can do is we can keep them in ketosis and their kidneys begin to heal. So I hope that answered your question in that regard. Hopefully that answers it. Miranda says, "Do you know anything about the A1C for gestational diabetes test instead of the glucose tolerance test?" Miranda, the challenge with an A1C test is an A1C test only tests an average. You can miss diabetes or pre-diabetes with just the A1C. So you can't use it if your A1C is above, in my perspective, if you have an A1C above 6.2%, you are diabetic. That means your blood sugar stays high enough that you're probably in the diabetic range. Although right now, if your A1C is higher than 6.5, you are a diabetic, period. In my office, if it's above 6.2, I'm pretty sure you're a diabetic. The challenge is that you can have, if your diet's been fairly good, you can have a more normal A1C and yet still be diabetic if we do a 2-hour glucose tolerance test on you. So I don't know if that was the question you had in regards to that, but if you have gestational diabetes, your risk of becoming a diabetic is like 25 to 35% in the next 5 years. So it's something that's very important you need to understand. Lucy says, "Is this info offered to doctors nationally in trainings. Well, this is actually new information. And like I said, these are the three most recent studies that talk about using a ketogenic diet with mammals. There are not any that I've seen yet, any larger studies that show humans and and a ketogenic diet with chronic kidney disease yet. Hopefully, one of the reasons I'm making this video is I may be able to stimulate someone to do so. And then Tina says, "Hey Tina, how are you? So can toxins in your body cause kidney disease because it's not filtering properly?" Well, yes, some drugs can act as toxins, and so if you use chronic non-steroidal anti-inflammatories like Motrins, Advils, ibuprofens, those can damage the kidneys permanently. Certain medicines that we use for other diseases like methotrexate and things like that with autoimmune disease can damage the kidneys. So there's some things. So those are reasons we want to watch your kidney function really closely if you're on medications. Certain infections can damage the kidneys because of the toxin produced by those particular issues. So that's something that can happen that way. Pardon me as my phone's ringing. Catherine said, I read that going keto would get rid of cysts on the kidneys. I have had patients, I've had 2 patients with polycystic kidney disease that decreased the number of cysts they had, because with polycystic kidney disease, one of the questions is the high insulin load a driver of the more frequent cyst formation? When we lowered the person's insulin by using a ketogenic lifestyle, they had a dramatic decrease in the number of cysts formed. And so that's what I've seen clinically. Now, I've not seen any literature on that at this point. So something to be watching for. Susan, let's see. Oh, Elke said, let me see here. Let's see. Any way to get off thyroid meds? Jeannie says, any way to get off thyroid meds? I got off diabetic meds. Well, Jeannie, the challenge with thyroid is that what I've seen clinically is we can dramatically improve thyroid function and in many cases decrease the amount of thyroid medications. But if your thyroid is already damaged or it's under functioning because of whatever reason, you may or may not be able to stop them altogether. I have patients that we've been able to dramatically decrease the number of meds, but not totally get rid of them. So it's a 50-50 on that one. What causes the keto rash? Well, Albert, the keto rash that I have seen in my office is usually an amplification of something called tinea versicolor. And I know that there's been some write-ups on a specific keto rash in some of the Japanese literature. I have never seen the rash they described. What I frequently see when people come into my office with a rash that starts after keto is actually tinea versicolor that flares up initially because your body's now getting rid of it. And so all of a sudden it creates this rash. And if you treat it and then ride through the keto, it usually improves. But I would have to see the rash specifically to know, is yours the true keto rash or is it something else? In 15 years I've been doing this, I have never seen the keto rash that was described in the Japanese literature that people keep talking about. They see everywhere else. I've never seen it. Will it help someone in their 70s or 80s with kidney disease with a ketogenic diet? Absolutely, Russ. Most of my patients are over 65. And as you can see, one of those patients was 71 and dramatic improvement in his renal function with a ketogenic lifestyle and closely monitoring his kidney function. Did we lose the sound again? Somebody says no sound. Marion's, hopefully this sounds, oh, it's on now. Okay, good. Can eating too much meat hurt your kidneys? Only if you're eating too much bread with it. That's the issue. So if you cut the carbs back and you decrease the bread, increasing the protein usually doesn't. And I have yet to see in the 20 years of practice a bodybuilder, and these guys do tons of protein, come into my office with kidney disease. It just doesn't happen. Do I consult doctors regarding keto? So I have some doctors. I've had some nephrologists come and ask what I'm doing with my patients, but I usually don't consult doctors unless you're actually my patient as well, if that makes sense, Lucy. So Grace says, my triglycerides are over 600. Doctor put me on Vasepta. What do you think of the medicine? I have not used Vasepta. I don't use it. I actually am able to control I have yet to not be able to control a triglyceride level with a ketogenic diet. There's nobody, all of my patients have been able to drop their triglycerides under 100 with a ketogenic lifestyle. And I've been doing that for 15 years. So thank you for telling me about sound, guys. So you guys do have sound. Okay, perfect. Not sure what happened there with sound with the person above. I forget her name. All right, let's see. Everything's fine. Okay, perfect. Well, you guys, it's been great. I'm going to roll this video over to YouTube here this evening. If you have any other questions, real quickly, pop them in the screen. people keep asking. Last video I did here in my office, they said, "Why are you wearing your stethoscope?" I wear my stethoscope in the office all day long. I'm actually in my office. It's lunchtime right now. I'm between seeing patients, and so it's easier just to leave it on me, because if I take it off, I'll forget it and then have to run back and get it. So I am a physician. I'm a board certified family physician. I see patients cradle to the grave, all sorts of stuff. And I use ketogenic lifestyles to treat a lot of what we do as a basis foundation. And then we use general medicine to approach beyond that. So that's why I'm wearing my stethoscope, for those of you that are wondering. And I just haven't taken it off yet. But I practice in Surprise, Arizona. I'm a board certified family physician, a board certified obesity medicine specialist. We'll turn off Grace's question here. Let me just see if there's any other questions there. What is an acceptable triglyceride range? So anything over 100 is not acceptable in my office. Your triglyceride should be under 100 in my perspective. The lab says 150, but in my office, it's triglycerides less than 100 is my goal for you. Mike St. Clair said triglyceride ratio is 95. HDL triglyceride HDL ratio is 95. Can that indicate good insulin sensitivity? Yes, it does. When your triglyceride HDL ratio is greater than 3, we're worried about insulin resistance. That's one way to look at it. But to be frank, I don't trust that completely, because triglycerides will change within 24 hours. So I will often do a small dense LDL particle and a fasting insulin level as well. Mine is inherited and keto does nothing for it. Grace, I have yet to have a patient not have it. Your high triglycerides is inherited because insulin resistance is inherited. And if you're treating the insulin resistance correctly, your triglycerides will actually come down. I have yet to have a patient that does not have that happen. It's been 15 years and I've been doing this a long time. So hopefully that helps. Do you ever listen to your own heart? With my stethoscope, says Brian. Brian, I do once in a while. Yes, I actually do. Let's see. Is there any pain associated with kidney disease? Not usually, Tina. I'm sorry, there's a little delay here. Is there any pain? Not usually with chronic kidney disease. No. And then let's see. Lucy says, please consider moving to California. Not until they change their laws there, Lucy. I'm sorry. California's a little too liberal for me. I am a type 2 diabetic, and that's good news. It is good news, Mike. It's fantastic news for people who have type 2 diabetes in regards to their ability to improve and heal the kidneys. So it's awesome. It is good news. So you're with your triglyceride ratio, triglyceride HDL ratio being 0.9 is actually wonderful. So keep up the good work there. Well, guys, it's been a pleasure to talk with you this I guess it's now this afternoon. I'm in Phoenix, Arizona. And I'm in Surprise, which is a suburb of Phoenix in the northwest corner. Remember, keep the fat high, keep the carbs low, and pass the bacon. And we'll talk to you soon. Take care and have a great day. Bye-bye.